Good morning, esteemed presenters. Thank you for launching this seminar series. This is the inaugural session of the seminar series for the Human Security, Public Health, and Population Wellbeing Working Group within the International Panel for Social Progress. As members of and collaborators with the working group, your scholarly thoughts and scientific insights amplify the importance of linking behavioral and prevention science to human security and quality of life. So we begin today with a look at the intersection of the Sustainable Development Goals, global and local public health, and good health governance. Dr. Srikanth Kondreddy's presentation on the role of the Sustainable Development Goals, its link to human security, and what could have been SDG on human security and how that evolved, and a discussion with our colleagues from University of Manchester on how the local context informs the global context. I will introduce our speakers from the beginning, all of them, and I begin with Dr. Srikanth Kondreddy. Dr. Kondreddy is a global health policy researcher, advisor, decision maker, and educator with a deep knowledge of the global health landscape, focusing on issues, initiatives, and actors. He's currently an associate professor and director of the Masters in Global Public Health and Sustainable Development program at the Richard M. Fairbanks School of Public Health at Indiana University. He's also adjunct faculty at the Guerre Institute at the University of Ottawa in Canada. His research and teaching interests in global health policy, global health governance, and global health diplomacy focuses on two pillars. One, global health governance, and two, global health diplomacy. And this focus has led to multidisciplinary research partnerships and collaborations from India, Canada, Australia, Switzerland, the United States, the United Kingdom, the Caribbean region, several African countries, and multilateral agencies, including the World Health Organization, United Nations Development Program, etc. His current research advances the political economy of global health, international cooperation in health, global health governance frameworks, the pandemic treaty or treaties, as we will likely have, international health regulations compliance, and global health security, among other areas. Professor Arpana Verma is a clinical professor of public health and epidemiology in the Public Health and Community Medicine Group at the University of Manchester in the United Kingdom. She's the program director for the Masters in Public Health and MRES courses and serves as one of the academic co-directors for policy at Manchester, where she brings academic expertise into policy conversations. She's the director of the Manchester Urban Collaboration on Health at the university, and that center is a World Health Organization collaborating center. She's also honorary consultant in public health at Public Health England, and president of the Urban Health section of the European Public Health Association. Her research primarily focuses on public health, health inequalities, COVID-19 impacts on vulnerable populations, and early detection and prevention of cancer. Dr. Greg Williams is a senior lecturer in public health and deputy program director for the Masters of Public Health program at the University of Manchester. He's well known for his educational and research contributions in global health, health services management, and public health communications. He's also a major player in urban health, the Urban Health Society for Urban Health, European Society for Urban Health. His research focuses on global health, health services management, and distributed learning. Within the MPH program at Manchester, Dr. Williams leads several critical modules, including health services management, global health into the 21st century, and business, media, and health. In addition to his teaching duties, he serves as the head of operations for the Manchester Urban Collaboration on Health, and his work emphasizes translating public health research into practical service solutions within urban and local communities. Dr. Christine Greenhalgh is a lecturer in public health and medical education at the University of Manchester. Her research focuses primarily on the climate crisis and its effect on health and well-being, planetary health, and nature-based solutions. She's widely known for her methodological expertise in qualitative inquiry and both quantitative and qualitative analyses. And without further ado, I welcome Dr. Srikanth Kondreddy. We look forward to a stimulating discussion this morning. And if I also might point out, we will have at least 30 minutes of time to engage members of the audience in questions and answer and further discussion. Thank you, Dr. Srikanth Kondreddy.
Thank you, Dr. Yonette. So can you all hear me?
Yes.
Perfect. So yeah, thanks for the nice introduction. And then I'm delighted to be joining this panel on this talk and discussing in the next 30 minutes or 40 minutes or so. So to start with, because as we're talking about the IPSP panel and then the human security working group, so I thought to have our talk on global health security aspect. So, but today's talk, I've chosen to have the intersections between the global health diplomacy and then global health security and how those global discussions gets translated into the local context. So that's how the title is framed. Okay, can you all see my slides? So as we know that we all know what diplomacy is, and then to some extent we do it in our day-to-day life, and diplomacy is fundamentally about the negotiations for pursuing something or pursuing some outcomes. So at a global scale, on a policy level, diplomacy sets the policy agenda for shared global issues such as the Sustainable Development Agenda and global health security. So these are the two examples. So there are many other areas, global issues where diplomacy helps setting policy agenda. And at the practice level, it promotes awareness of the global issues among the stakeholders and to increase the international partnerships to achieve those, to address those issues, and also helps in improving the regulatory environment. So these are the things that happens at the practice level through diplomacy. So if we go back to the histories a bit here, so diplomacy played a significant role, be it in discussing and Millennium Developmental Goals, and that's where it emerged out of Millennium Developmental Declaration of 2000. That gave the impetus to have the Millennium Developmental Goals that we know today. So those are the 8 goals. We have moved from that phase to the SDGs. So even from the transition from MDGs to SDGs, so there's a lot of discussions and a lot of negotiations happened across the countries and across the systems, and lots of delegations participated in these diplomatic negotiations, and then leading to the Sustainable Developmental Goals, transitioning from MDGs. So from transitioning from MDGs to SDGs, as I said, there was an intense diplomatic dialogue between the among the member states. So this is how you can see here in this slide. So where in 2012, uh, there was a conference like United Nations Conference on Sustainable Development. In other words, which was held in Rio, in Brazil, and in other words, it's also called as Rio Plus 20 conference. So this gave the momentum uh, to start reflecting on the progress of MDGs, and then the way forward from MDGs to the post MDGs dialogue. So the outcomes of this conference is to have was to have basically to set an agenda for the post 2015 agenda. That is, in other words, sustainable development goals. So basically, this conference invited nearly 45,000 delegates across the world, and wherein 88 members, heads of the states, gathered in Rio, and to discuss the way forward after the MDGs. So this discussion and this conference led to the creation of, or to set the agenda for the sustainable developmental goals. Basically, before we get to that stage of sustainable developmental goals, so this was the time where people were started discussing what post 2015 would look like, and what kind of goals that we should frame, and then the targets that we should be framing. So basically, it helped to create to set the agenda for the post 2015 dialogue. So because it happened in 2012, when the SDGs were adopted in 2015. So there is a three-year time there. So this is the time frame wherein we have lots of delegations, discussions, and negotiations and diplomacy happened at the time. So before that, so there was a conference in Rio in 1992 that is called Rio Conference, and after 20 years, again it was a conference held in Rio. It was also named as the Rio Plus 20 Conference. That sets the agenda for the Sustainable Development Goals. So as I said in the previous slide, so there was time from 2012 to 2015. That's the time where the discussions and the negotiations and diplomacy happened. So during that time, as we were transitioning from that side of the discussion to the post 2015 discussion agenda, so as member states were discussing and framing the post 2015 development agenda, so there was an outbreak that happened. So the point I'm trying to highlight is that this outbreak kind of interrupted those kinds of discussions, the multilateral processes, and also created an opportunity to include a goal called Global Health Security Goal to the 17 Sustainable Developmental Goals that we know as of today. So as we know that the 2014 and 16 Ebola outbreak, that kind of created some sort of a big event in the global health history, I would say. So it didn't become the global pandemic as such we have seen it in the case of COVID, but it has the potential to become a pandemic at the time too. So basically, this Ebola outbreak occurred in Guinea in 2013, and then it spread across the Sierra Leone, and then the Liberia, and then Guinea. So these are the three West African countries where predominantly this outbreak was witnessed, wherein if you look at the epidemiological numbers, so it was like 28,000 plus more case findings, and then almost 11,000 plus mortality rates were reported during this time due to the Ebola outbreak. So an Ebola outbreak that happened had a huge potential to transmit across the borders. So that's what you can see in these slides, where it could spread across almost 6,000 plus kilometers. So that's the scale at which it could the transmissible point of this outbreak at the time. So as there was an intense dialogue, there was an outbreak. Parallelly, we were discussing the Sustainable Development Agenda, and then there was a disruptive outbreak that happened in the name of Ebola at the time. So that was the time, and that was an opportunity, and there was an opportunity for global health people to think about what if there is there a possibility to add one more goal in the name of global health security. So this slide is basically to show this, I mean, the outreach or the the periphery of the outbreak. So as I said before in the previous slide, it had the potential to reach the, I mean, across the world, across the globe, for at least 6,000 plus kilometers. So that's what. So though it happened in the West African countries, so it has the potential to become the pandemic at the time. So so as I said, so there was a discussion whether to add, shall we have had another goal on a specific goal for Sustainable Developmental Goal 18 on global health security. So basically my presentation, my talk is primarily emphasizing, just to give you some sort of sense about this SDG 18 on global health security, because not many people would know about this goal, because it's not there in the, it's not adopted as a goal. So that's how we don't see it as a goal. But there was an intense dialogue or some sort of thinking that happened during 2014 and 16 time, just because of the Ebola outbreak. So there were a group of people who thought through to have a goal or to be added as a SDG 18 to the existing 17 goals that we know as of today. So basically, this proposition that was proposed at the time was just to take an appropriate action to reduce the vulnerability of people around the world to new, acute, or rapidly spreading risks to health, particularly those threatening the cross-border, cross-national, cross-international borders. So this is how the thinkers framed. So what if there is if we need to have a goal, what kind of goal that it should be, and then what we will be looking at through this goal. So this is how, so they have framed a definition or a kind of a focus of this goal on global health security. So it also encouraged the negotiators to define. So basically, the Sustainable Developmental Goals and Sustainable Developmental Agenda, it's basically a multilateral diplomatic process or a negotiation process. So not many people would really be able to participate in those multilateral or multi-level, I mean, highest level of policy decisions. So the academics and the thinkers, primarily, they can influence the policy processes or the governance processes, but not necessarily they all would take part in those decision framing or policy making. So basically, through this goal or through this proposition, so these global health thinkers encouraged the negotiators, the meaning that the people who are actually part of these delegations who negotiated these discussions or the sustainable developmental goals. So and these global health thinkers encouraged those negotiators to define SDG 18 more precisely and to bring stakeholders on board. So during SDGs negotiations at the UN process or UN system level, or at the 2015 World Health Assembly level and the G7 meetings and the upcoming BRICS meetings at the time. So I'm just giving a historical context of 2015, what has happened during that time. So basically, the thinkers encouraged the negotiators to discuss these things as much as possible in all these policy venues, like, for example, the United Nations General Assembly, World Health Assembly, and then G7 meetings, etc. So this is how there was a momentum to add on another goal on, in other words, the Sustainable Developmental Goal 18 on global health security during that time. So since it's a as I said, it's a multilateral process, and it takes time to get those items into the policy agenda. So that's why I realized there are a couple of points on this slide you can see the interest. So even if we advise or even if we encourage the negotiators or the policymakers to consider few things, So it should resonate with the policymakers, those who makes the policy decisions highest level, especially in the global stage, and willingness. And then even if a civil society or a kind of advocacy or policy advocacy happens, so it has to resonate, and then they need to take it. So, in other words, the political will of the leaders or the member states is at the is a critical point, and the timing too. So, had there been enough time during 2014 or 15 time, so there would have been a possibility to add this goal, but the timing that the idea was proposed was too late, I guess. So that's the reason why it couldn't get translated into or got some sort of momentum that it should have received. And the legitimacy is the last point where, so no matter what, how much we advise or advocate, it is the negotiators, the legitimate people who are at the process of negotiations. They only can take those decisions. But the academics are the kind of thinkers who can only influence the process. So that's what I put it as the legitimacy aspect. So these are 3 or 4 items that I realized are critical aspects in diplomacy process. So that's what I understood. So I just want to highlight this point to you as well. So, well, the goal did not get translated as such that we have hoped for or envisioned as a SDG 18, but then it gave us some sort of momentum for governance reforms. So it all happened just because of the Ebola outbreak 2014 and 15. So though there wasn't a goal as such in the SDGs list, but then it gave some sort of momentum to create governance reforms, global health governance reforms. So as you can see here, in 2014, when the outbreak occurred, it's Dr. David Nabarro was appointed as the UN Secretary General's Special Envoy on Ebola to coordinate this global response to the Ebola at the time. And in 2015, the first time ever, there was the contingency fund for emergencies was created at the WHO level, which is like a short, small contingency fund with the WHO, just to address if there is any emergency, to use those contingency fund to address it within a limited time frame of 24 to 48 hours or so. And then the interesting point is that in 2016, as part of the governance reforms, for the first time ever, so the Global Health Emergency Program was created or added to the WHO's portfolio of programs. So this is the unique aspect that happened during as an outcome of the outbreak. So diplomacy, regardless of whether we failed or whether we have, it's true that we haven't been able to add that goal of sustainable development, SDG 18 on global health security, but then the diplomacy is always there, and it happens all the time. So during the time of MDGs transitions to SDGs, the diplomacy was there, and then even the progress that we are looking at, SDG progress as of today. So there is some sort of diplomacy or negotiations going on to fast track these goals, even including the global health security thing. So you can see here in this slide, basically, I pulled it from the SDG report recently that was released in 2025. We might be wondering, so what's the progress? It's been almost 10 years after we adopted those SDG goals. So what's the progress? Probably I thought we should have a slide on this. So this slide basically reflects the progress that we have made over the last 10 years or so. It's only the 18% progress that we have made. In other words, we are on track, and nearly 48% we are kind of maintaining the status quo, meaning that we are not making progress as such, but then we are just maintaining the targets as we have hoped for. And the sad part is that so we are not at all making any progress on certain things, which means the 18% we are regressing back. So the progress that we have achieved, we are not at all moving in that direction. We are kind of reversing back to ourselves. So meaning that there's only accumulative progress is only at 35% or so. So that's the state at which we can see the SDG progress as of today. So the last part of the presentation is the global to local. So basically, what does global to local and global health is all about? So it's a practice of applying global health solutions and innovations to address specific health challenges within local communities. So as we all know that health is very local, and health issues are local, and the strategy is basically at the global scale. So the fundamental aspect is that it's a adaptation both at the local level or at the global level. So that's what makes it unique when we call it as like global to local and global health. So the adaptation is a critical word. For example, now currently we're dealing with the Ebola outbreak in DRC and Uganda, and then hantavirus outbreak just 2-3 weeks ago we were talking about it, and this week and last week we were talking about Ebola outbreak in DRC and Uganda. So basically, in order to address this Ebola outbreak, even the current outbreak, we have to apply those global norms, global frameworks, for example, the international health regulations, to address these kinds of things. So this is what I find it useful and to situate when we say that global to local, the international norms such as the international health regulations needs to be adopted to the local conditions or the places where the outbreak occurred, and to support the communities there. And that's how we can contribute to the global health. So it's not about, it's basically it's a process. So as much as we talk about adaptation, so it's not always true that the global health norms or frameworks or other governing frameworks needs to be adopted at the global level or at the local level. So it's also necessary to understand, so there is a unique set of knowledge or unique identity or unique ways of addressing health challenges among the local communities and at the local context. So those things also need to be translated or into the global processes, and meaning that the adaptation process is not the unilinear path, it's just like cyclical path. So it should happen both ways. So as much as we hope for the global processes should be adopted at the local level, and the local process should also be feeding into the global process so that better informed policy making and policy decisions at the global scale. So this is how I see it, as a circle, rather than it's a unilateral or unilinear path to the policy making. So I'll stop there, and we will have questions and discussions on these aspects. Thanks, Yonette, and thanks for your attention.
Thank you, Professor Srikanth. Again, I knew you would be judicious. You have 3 minutes to go. Can you hear me? So
Yes.
If we can have our colleagues join so that we can get perspectives. Who would go first? And if you don't mind, I will do first names, okay? From here on to make it easier. So I don't know if Arpana, if you'll go first and share your insights in response to Dr. Kondreddy's scholarly thoughts, and who.
Thank you, Yonette, and thank you for a very inspiring talk, Srikanth. It really brings home the importance of why we have our organisations across a global perspective to help us with our public health emergencies and emerging infections, and the responses that we have to be able to understand the importance of that global picture for public health. And so for us, we've been looking at various different opportunities for growing the local responses to global problems. And whether we're talking about capacity building or whether we're trying to think about how we build salient research questions from a research perspective, and then how all of that feeds into policy and practice. One of the core goals for us in this current climate of the issues that we're facing post-pandemic is sharing of information, and for that harmonisation of activities. And as Yonette mentioned, we were a WHO collaborating centre for health indicators, looking at that global ability for us in this day and age with all the technology. How do we actually get the right data at the right time to the right people to do the right actions? And how do we close the loop to be able to understand what we've done, whether it's worked, and what's worked and why, and how do we fail fast? So some of the key pieces of work with our global partners is to think of something like a rapid cycle evaluation as a way of us thinking of how we do that strengthening of our global relationships and ability to provide an action in a more rapid way. And then the third thing was to think about then how we mobilise our workforce. And so you mentioned Hunter virus and also the current Ebola crisis, and these are really great examples. So we often may not be involved in the direct prevention and control of an infectious disease, but we're often managing our population's ability to respond, and also some of the fears that people have. So what does it mean to our local populations, and how do we understand our populations enough to be able to talk through some of the key issues associated with these global issues in terms of risk communication? Yep. And being able to give appropriate advice. So, for example, on travel, if there's essential travel needed, and how do we also train our workforce who may be mobilised for these international emergencies? And I'm sure you know that the UK provided a lot of the expertise for the last Ebola outbreak and learning the lessons all the way through from PPE through to prevention and control of those outbreaks that were occurring at the time, and the ability for people to then come home and be able to be safe whilst they're doing their very valuable work. And so I feel that this is a real important part of public health practice, that we have discussions like these where we can inspire our public health workforce wherever they are globally to think of themselves as one community, as one team, and be able to support each other as we face different crises at different times. And another key example that Greg and Christine have been working on is having a look at the interaction with the climate crisis and the issues that we are currently facing. So we did some work with our strategic partners with the University of Chile. And we could have chosen anything. And the key priority that our public health partners, both here at the University of Manchester and the University of Chile, chose for the first one is how climate change is going to mean that we're all going to have to rethink the incidence of infectious diseases and what we'll be seeing as the climate emergency progresses, from those diseases that may be from more tropical climates moving, and also things like the global mobility. And I know from the IHR perspective, one of the key things is, when do we actually close down borders? And I'm sure every country post-pandemic has been discussing our need for lockdown versus our need to ensure the economies and the populations who are most vulnerable to slight economic shifts, who are likely to therefore suffer the most from both the climate emergencies and infectious diseases, are actually our most protected populations when we start to think about how we plan for these types of emergencies. And being able to think that through on this global to local scale allows us to share that information and to be able to be greater than the sum of our parts. And I hope that what the pandemic's done for us in public health is provide the platform that public health is everybody's business now. And what we are always saying is that it's everybody's business, but not everybody knows how to do it. And so whether we're talking about misinformation, disinformation, whether we're talking about how we look at our vulnerable populations, and only this morning here in the UK, I'm sure Christine will talk about it further. We've got recommendations about how we're going to how we're going to cool our places of highest vulnerable populations like hospitals, care homes, and other structures where we'll need to think about not just heating but cooling going forwards. And some of the key infectious disease outbreaks that I've been involved in have been actually associated with air conditioning and other sources where the vectors may actually be inbuilt into the structure, into the fabric of our built environment. And so the last thing I was going to say is the importance of urban health. Health in all policies. This is our 40th year of the Ottawa Charter, and having that shift from health promotion to health improvement. And I know that there's a lot of work that WHO are doing on the evolution of the Ottawa Charter going forwards. And I think urban health, whereby this is the juxtaposition of lots of different vulnerable groups in a small, densely packed geography, so dependent on the built environment, the social environment, and obviously health and healthcare and well-being services being co-located but still difficult to access. And so I always teach our students about the fact that here on our university campus, we have one of the largest universities in Europe, but within a 1 mile radius, we actually see some of the worst outcomes for our populations. So to end my reflection, I think that this is where urban health has a very important place to think about how all these different components fit into how we respond locally and globally. And our emerging infectious diseases are going to be influenced by climate change. And we need to think of health in all policies, our health improvement practices for the 21st century to get our populations ready for whatever might come. And very grateful for this opportunity to be able to speak to you today. Thank you, Yonette.
Thank you, Arpana. So insightful. And Srikanth, I saw you taking notes. I know you want to respond, but let's give Greg and Christine a chance to add their insights, and then I'll come back to you. The one thing I want to say quickly is, Arpana, you mentioned IHR, International Health Regulations, and Srikanth is an expert on that. So to the point where on July 9th, we will have another seminar presented by him on the International Health Regulations for Global Health Security. So may invite you back. So stay tuned if you're available. And it's a Thursday, not a Wednesday, Thursday, July 9th at the same time. So more on that. Okay.
Yeah, we'll look more into the technical aspects of IHR, and then some of the operational issues, the norm compliance, where countries are faulting, and we'll talk about that.
Yes, excellent. Okay, so Greg and Christine, either one who wants to go. Greg, you look ready. Go for it.
I took some notes. I'll just quickly go through some of my what I was thinking, and state actually it's interesting you mentioning the IHR, because I'm going to touch on that, because I think when we talk about global health security, because actually I can't remember whether you said it in my introduction, so I'm Vice President of the Global Health section of the European Public Health Association, and one of the big questions we had was whether we might change our name to Global Health Security. But when we were having the discussions, is one of the issues we came across was we don't think people generally on the ground know what that means, which is obviously an issue in itself if we get there. But that again comes to this communication issue we have. And it's interesting, the concept of it being SDG 18 with the importance of it, but then equally there will be lots of people who think that something else should be SDG 18. And we know we've had debates from people who thought that SDG 3 should solely, the health one should solely have been universal health coverage as the target for the whole world, and all the targets within there focused on there. So it's interesting, a lot of the things, how people conceptualize global issues at a local level, but there's also the challenges on them, and considering a local level, like you put on, like you mentioned, Srikanth. So with implementing, and I will look forward to coming to your session on the international health regulations to hear some of them, how we do declare it a public health emergency of international concern. But even though there is the checklist of things to go through, there are things we need to consider, like we saw with Mpox and the stigma around LGBTQ plus communities and how they need to consider that. We've seen it with Ebola in the Democratic Republic of Congo, with the issues around what enacting some of the mechanisms would have as an impact on the country. So obviously there are questions. I know there is a debate as to how suitable the IHR are. And with, like you say, there's no compliance enforcement mechanism, no sanction for failures. Do we want that? It comes into something I'll just go to a little bit later, because I wrote a note about some stuff to do with the pandemic treaty, which is obviously going on. Is the global world actually like that? And how prepared are countries? One of the things I found quite interesting when we had the pandemic was ironically timed in about, I think it was November 2019, Johns Hopkins released their first version of the Global Health Security Index, which said that the two most prepared countries in the world for a pandemic are the United States of America and the United Kingdom. And I can see some laughing, because I'm pretty sure most people will say that this is not what actually happened. They were not the most prepared. But if you actually look at the index, some of the indicators, like Pan was saying, we deal with health indicators. They might say how physical infrastructure is in place, but they don't say about who's in charge of making the decisions. And we know there's a lot of things that went on there. And Pan is talking about how we deal with things locally. In the UK, we know there were lots of contracts that went out to inappropriate people when we could have done things with local track and trace schemes in the actual local authorities and things like that. And then obviously there were the delays in declaring COVID as a public health emergency of international concern. But in a way, I think there's a balance, isn't there, with pandemics, because people are aware of them in communities because everyone experienced it, but that's got its positives and its negatives. So we're seeing with hantavirus now, I've already heard people saying they're never going to go on a cruise again for the rest of their lives. And also the media, because everything gets, there are immediately going to be webinars, things like that. So they get discussed about straight away. But as a partner touched to as well, whenever you're making your decisions, it impacts different groups differently, doesn't it? We saw in the pandemic, older persons and younger persons being impacted for very, very, very different reasons. So we have to consider what we're doing that. And then obviously now global health security is a bit more of an issue that people are realizing that we need to be prepared. But as we've done some work with people from the HERA, which is the Health Emergency Response Agency for the EU, but that came in afterwards. But now there's also questions with stockpiling of medicines, and then obviously the impacts between high-income countries and lower-income countries. And we saw it in the pandemic with vaccines. And even though there is a provision in the trade-related intellectual property rights agreement for waiving of vaccines, that was such a challenge. And even if it got there, would there be waiving of vaccine patents, even if it got to the stage, do all the countries have the capacity to deal with them to actually create them? And we did see a lot of nationalist responses in the pandemic. But there is also the side of the coin that sometimes it could be positive. We saw in the UK people being desperate for the UK vaccine because they turned it into a bit of a UK versus Europe issue. But now we're seeing with the misinformation and things with the pandemic agreement that's going through. Somebody, a colleague at the World Health Assembly, sent me a photo of a bus with no to the pandemic agreement.org, I think it was, or something. And then there is this issue with misinformation on there. There are problems that people are saying with the pandemic agreement or treaty or accord, however you want to call it, with whether it had the relevant stakeholders, the financing, whether it protects human rights. But now there's a lot of misinformation because people were told all these things that WHO apparently implemented in our communities during COVID. Like they saying they forced the vaccines on everyone, and this is what the pandemic's going to do. It's going to overwrite national laws. They forced all of these lockdowns, which they didn't. They advised things. They can't force this and override national laws. But then again, these issues are out there. And how do we deal with that in communities about global to local? How do we inform people that that's not actually the situation, that things are delivered locally and nationally? But then there is these national issues. I know there's the American First Global Health Strategy. It's that we're now shifting towards where we used to have a lot of International Monetary Fund issues to do with the money side of things. But I know now there's a debate about data sharing. So for America, the US, to help a lot of countries in low and middle income countries, they've got to share the data. So that comes down to trust. I know a couple of countries have already rejected deals with the United States as a result. Because if you're at a local level, do you want your data to be going out everywhere, whether it's for good purposes or bad purposes? Again, how do we translate that to local people and inform them and make them aware of all this misinformation that might be out there, or what is good and what is bad? So it's quite difficult. But then on a positive note, I'll end on before I pass to Christine. There is something we always teach for our students about the Sustainable Development Goals, is people don't realise how they can contribute in a positive way themselves. And in fact, lots of them actively are contributing. because it's a global goal, people just think it's out of their capacity, out of their reach. But there are ways, and that's something we do a lot of in our university towards the sustainable development goals. So yeah, there is positives to it as well. But yeah, I'll leave it at there, and I'll pass over to Christine.
Thank you, Greg. Christine.
Thank you. Really interesting to listen to everybody, and thank you, Srikanth, for a great presentation that really got me thinking. As Yonette mentioned in the introductions, my interest is mainly centred around climate change, and I think that's particularly relevant here. I've already heard a couple of you talking about it, and it's only, we know now that, and have known for quite a while, that the climate crisis is a health emergency, a global health emergency, and a massive threat to our global health security. And yet it was only very recently that health even was mentioned at all in the major international discussions on climate change. So when we talk about diplomacy, really interested to hear you talk about diplomacy, Srikanth, and making me think that, it's particularly relevant to climate change. If we think about diplomacy in the climate sphere, we have to sit back and think and realise that in the 33-ish years of global climate action and global climate diplomacy, we have to say that pretty much it's been a complete and utter abject failure of global diplomacy. Whilst it has achieved certain things, it hasn't achieved the core goal of bringing down emissions. Emissions have been steadily rising all the way through those 30-odd years of climate diplomacy. And the core tenet of the only real significant international agreement we've got on climate change, the UN framework on climate change, the core goal of that is to remain under 2 degrees and as close to 1.5 and hopefully under 1.5 degrees of warming. And it's quite clear that now we're not going to be able to maintain 1.5 degrees. We'll be overshooting very shortly. And so global climate diplomacy has been completely ineffective in its core tenet goals. And what is truly interesting, I think, to me is, again, you talk about global to local, we always mention global to local. But again, the climate change sphere shows us that where action really can be effective and where it really matters is on the local level and taking local things to the global stage. Most of the inspiration we have for significantly effective climate action has started on a local level with local people, making solutions for themselves to the issues that they face more often than not even realising a lot of the time that they were actually acting on climate, because that wasn't necessarily what they set out to do. And a lot of these local solutions that local people are devising and developing for themselves could easily and have been easily in many cases been scaled up and could be global solutions. Another good example of that is the C40 city movement. Manchester is one of the C40 cities, a group of city administrators who got together because they saw that their national leaders weren't producing the goods, and got together and created their own initiative to try and take climate action on a city level, which has been really effective. But I think perhaps one of the most effective that we've seen recently, and perhaps a really good positive diplomacy talk to finish on for me, was over for several years, grassroots action was calling for a fossil fuel non-proliferation treaty. They saw that, again, the global diplomacy was failing and not ever asking for a phase out of fossil fuels, which is what we really need. And so they said we needed a global fossil fuel treaty. And the movement began several years back now, and a very inspirational lady, Sapora Berman, won the Climate Achievers Award and got some money to be able to put this into some kind of realistic campaign, and launched the campaign for a fossil fuel non-proliferation treaty back in 2020. And it's grown and grown. There are now 196 subnational governments, over 4,000 organisations and institutions and businesses, and over 1 million individual participants calling for this treaty. And it's been so successful that it was credited as being one of the inspirations for the Netherlands and Colombia to host the fossil fuel phase out conference in Colombia very recently, which to all accounts was incredibly successful, introduced a new way of negotiating, which went down really well. And notably, they invited, it was an invite-only event, and the notable big hitters, if you like, in the climate world, the US, Russia, India, China, Saudi Arabia, and some of the other Middle Eastern countries, weren't invited. And that's partly seen as one of the successes of the conference, because those were the countries who were usually stymieing progress and stymieing agreements. It's been seen as an incredibly successful event, and there's going to be a follow-up next year hosted by Ireland and Tuvalu, which we can all look forward to. So I think it's really interesting, the fact that the global diplomacy hasn't worked for climate, that local diplomacy has, that local grassroots action. And sometimes I think maybe instead of thinking about global to local, we should really be focusing on local to global and looking for our inspiration there. Thank you.
Brilliant. Really good point. Local to global. I've come around to that. Thank you, dear Arpana and Greg and Christine, for that. Now, Srikanth, some thoughts on what you heard from your colleagues, and then go to Q&A.
Yeah, so it's very interesting to hear three perspectives here. Arpana, spoke about the community perspective. That's what I understood, and Greg was more of a global health sovereign political context he articulated, and then Christine articulated how the global diplomacy failed in terms of in the case of climate context. And I truly agree with those points with each one of you. And of course, yes, there is a lot of correlations between the climate change and the outbreak diseases, infectious disease outbreak, Arpana. And I definitely I do get sense of it. And when it comes to Greg's point about pandemic treaty and vaccine sharing and access to information, many other things. So these are all big political and policy issues where we know that the pandemic treaty somehow we could, with lots of amendments. And in fact, I was part of many of those pandemic treaty discussions. Doing my work with the government of Canada, and I participated in lots of stakeholder consultation meetings, and I've seen how the pandemic treaty wordings were tweaked every single time when it went to multilateral levels. So And of course, we all know that the US did not ratify it or agree to it. And then, of course, despite of some progress and some success in agreeing the pandemic treaty, and we have had to come up with an annex document, but then which was supposed to adopt this year, the current assembly time, but then there was some sort of no progress in that aspect. So we are hoping next year or next assembly to have it ready, but it's a bit tricky because there's a lot of political aspects involved in it, and then the sovereign aspects involved in it, and I certainly don't know how the exact pathway to navigate the system. It's equally I was reflecting when I heard of you. It's global health is basically a complex adaptive system, and it changes. Things get adopted as based on the conditions and circumstances, and then coming back to your point, Christine, and it's true that when for example, in the climate case, it's not diplomacy truly failed. We have classical number of examples to articulate in that aspect. So for your specific point about it's not the global diplomacy that worked for climate context, it's a local thing, local diplomacy that helped. It is, we know who the faulters are when it comes to climate change, 1.5 degrees goal to achieve. And I know, like, I have worked with some of the colleagues in Colombia, and how they are contributing to the climate change effort. So likewise, there's several examples across the world where the local communities and local practices are kind of replicable elsewhere, because they are the best practices when it comes to the climate change and climate protection, sustainable environment kind of a thing. So I don't know how a quick fix solution for many of these bigger aspects, but I do value each of your thought process. And I think it's a slow incremental progress, I would say. So that is how I'm seeing things happening.
Well, we have to create a movement. Brazil started it, and it's really, I think, on the note from the local to global, there's a movement around the world where what happens at the local pushes to global change. Brazil, what we saw in Brazil at the last COP was really, again, reiterating that. And things like the Think 20 and the various bodies that inform the G20 are playing a major role. So, and I think the International Panel for Social Progress are definitely our working group on human security, public health, and population well-being could be instrumental in amplifying this local to global, because I think that's where the change happens. The WHO and UN bodies are member state oriented, and they go at the national level. Well, as you know, in our own working group, we have subnational, what are the partnerships at the subnational level? Our focus is heavily on subnational and municipal, and that's what's important. What you guys are doing in Manchester, that local level, is amplifying. We're seeing it at the Healthy City Design Congress coming up and the European Public Health meetings, what we see in Brazil. So there's hope. And definitely Africa CDC is focusing more and more on the local context and how that informs local academics and people in public health practice, et cetera, like ourselves, thought leaders are being more instrumental. So I believe the glass is 3/4 full and there's hope. So we have to keep forging on. On that note, I want to bring in our audience. We have a few people here. I see Karthika and Mabel and Wendy. And I know, Karthika, you, with your group, you all think of these issues at the local level. So, and Antonia, and please come in if we can have everyone up on the stage. Dear Bokanjo, or esteemed Bokanjo, and hear from them. And I see Margot, who is the Executive Director, Co-Executive Director for the International Panel on Social Progress. Dr. Margot, you are heavily involved in the Think 20 issues. Maybe some thoughts on from you on how this work and our working group can be informed. So if everyone can join in, if you raise your hand, I'll call on you. We have another 25 minutes on this, so let's discuss. Okay, I'll put on my professorial hat and call in people. Any thoughts, Karthika or Mabel? Wendy, I see you there, Wendy. Any thoughts? Margot, Antonia? I don't know if they're vocal. Can we get people on the stage, Bokanjo? There's Margot, I see you.
Yeah, just a quick word for everyone that is in the attendance. You can join the stage by accepting the invitation that I sent to everyone. So just make sure you see the notification and validate it so you can enter the stage.
Okay, all right. Wonderful. Margot, Think 20 thoughts?
Yeah, well,
start it off.
I just want to, first of all, thank you and the leadership of the Human Security, Public Health and Population Wellbeing Working Group for the excellent work. I think this is a well-conceived series, and I'm delighted that it's off to a very rich and encouraging discussion with this session. So thank you on behalf of the leadership of the IPSB. In terms of the opportunity or the pathway, I'm quite excited to hear how best we can position this group to add a voice to the discussion as the United Kingdom takes the presidency of the G20 at the end of this year. There's the leadership on the UK side is still making decisions about their priorities, but I find it hard to believe that there won't be some focus on planet and climate. And so I am engaged in some of those discussions and will be working closely with the members of this working group. For example, drawing on this discussion today to help advance that agenda and position you to write a policy brief, which in the Think 20 is one of the ways of making recommendations to the leadership of the G20 and the G20 heads of government when they meet. And I'm excited about the possibility. So it's now on my radar, and I will be following up with you. And once again, thank you all for this rich discussion. But the other point is, with the International Journal for Social Progress, we also have an opportunity. It's not an IPSB journal, but we're advocating that these topics also be included as the journal picks up pace. So over to you. Thank you.
Well, thank you for that. And Srikanth and I, several years ago, when the Saudi Arabia had the presidency, contributed with a policy brief that was very significant.
Yes.
The health as a global public good.
Yeah.
So
I think you have an opportunity to repeat that.
Yes.
So definitely, let's go for it.
Okay, thank you. Wendy, I see you there. Any questions, comments for the panel discussion? You're on mute.
Yeah,
there you are. Okay.
I was just looking for the unmute. Yeah, that was a really fascinating discussion. Thank you very much. I'm really interested in this axis between global and local, and then bringing in that communications challenge that you a number of you touched on about. I think you're using terms like misinformation, disinformation, and so on. And I often find that as we translate from the global, we aren't using the right language at the local level to really drive the kind of engagement and dialogue. And I would just really welcome your advice on how we navigate that global to local, but with much better communication, because the kind of work that you talked about, influencing the diplomacy, relies on communication that drives engagement and behaviour. So I just welcome your advice in that space, and thank you very much for the interesting comments today.
Great question, Wendy. Thank you. Srikanth, Christine, Arpana, Greg, anyone want to respond to that? What you guys are doing some of that work, Greg, with the European Public Health Group and locally in Manchester.
Yeah, I can just say on, especially you mentioning the misinformation and disinformation and things, and there is something in the way that we communicate with people in taking away from, especially when a lot of people say, this is my opinion, and we know it's against scientific facts, for example, and trying to take away from the negative language of, like, stop being an idiot, why do you feel like that? We need to learn from that. I know it can be really easy to do that, but it doesn't, like, why should they respect your opinion if you're just telling them how wrong they are and how stupid they are? And that can be difficult on many levels. And there's also, especially when we are talking about people, things like climate deniers and vaccine deniers, there is the idea that you're never ever going to convince the absolute main person, the staunch denier, but you might convince the people that follow them and the people that are around them, and that's actually your target group, not the staunch denier of things like this. And again, it comes into that communication level of it, and also appreciating that what a lot of people will think of, that we need to appreciate the people we're speaking to and their own ways of doing things. Like talking about Ebola outbreak, like the way that you can't, even though it would be ideal that you don't wash, you don't touch the bodies. We know that in some communities it's important, that ritual. So we have to, rather than just say you absolutely cannot, give them ways to understand how you can do it in a like a harm reduction way, and make it as safe as possible, and not just assume go to the very top absolute advice, because it's not practical when speaking to people. But I'll pass it over to her because she's got her hand up.
Yes.
Well, thanks, Greg. Yeah, great question, and something we're doing here for our work with communities, because we're very culturally diverse in Manchester, and trying to understand where the trust was lost with our statutory bodies, especially since the pandemic. And I think it's, as Greg said, how do we build that trust so that we've got lots to learn from social media influencers, from social marketing, from even how big business are able to communicate with our populations. And it's often a lot better than we are communicating our messages. And so having true co-production, so moving away from that tokenistic involvement of people who matter the most, to giving away our power, because that's the other thing. Stop telling us that you're empowering us. We've already got the power. It's just that you're not listening or not asking the right questions. And very much seen firsthand when we train our community researchers, they get much franker and honest answers back from our communities than if we're the researcher going in asking. So what I've learned over the last 25 years is we have that ideal of the hypothesis-led research, and I think that for the 21st century, that paradigm is not fit for purpose. We've got to start drafting our communications, by true engagement. And none of this is new, but I think in this age of how we think about the influences of our most vulnerable in the population, it's getting that true co-production, thinking of culturally sensitive and diverse populations that all require something different, because one size definitely doesn't fit all, and then pulling our power away from us, either as researchers or the statutory bodies, to give it to our communities, and they'll do the work for us. As long as Greg said, we do it in a sensitive way that actually allows those communities to make the decision. And after all, as we mentioned, the Ottawa Charter, it was all about making the healthy choice the easy choice. Mm-hmm. And I think we've made the healthy choice the very difficult choice over the last 40 years. So how do we readdress that? But great question, Wendy. Thank you.
Okay, brilliant. We'll keep talking about this and thinking this through. More to come. Thank you for that. Any other thoughts? I see Karthika. I know your group has been thinking about this. Are you able to hear us, or are you able to respond? There you are.
Hello.
Karthika.
Hi. I'm sorry. No, it's just my network has been in and out today. So I just did not want to come in and disturb the flow of the conversation.
Okay.
But no, and honestly, I'm not, even though I've not been as close to this particular field of study as much, but this was a very, informative, 30 minutes just to give us more context on what is it that we truly need to be focusing on. So I just wanted to thank all the participants, the presenters and discussants for that. And honestly, just to hear around for just more thoughts from all of you than anything much to add today. But thank you for having me here today.
Okay. Brilliant. Thank you. And I'm glad you have some connectivity that you could join. So stay tuned, more to come. Thank you. I see Mabel, Dr. Mabel out in Zambia there, or in Lusaka. Do you have connectivity that you can speak? I'm not sure. There you are. Yes. Your thoughts.
You hear me?
Yes.
Oh yeah. Thank you so much for this opportunity, and also just for listening in. Been great discussions. Just a thought, when I was listening in, I think some of the broader thinking were around that it's very important to connect to global stages like this one, even as we are looking at health, looking at global security. Looking at local security as well, it's very important to connect to global stages so that synergies are connected, so that certain pieces in the local context are not left out. So for me, I think I was very interested in just learning how this whole global conversation, it trickles down to local context, but also vice versa, how the local context then builds into this global atmosphere. So really thank you. And also just to echo on the public health securities, the global health securities, local health securities that are happening, the Hunter virus. I know that currently Zambia is affected indirectly affected by the Ebola virus. I know the DRC is just close to us. And just recently, our Ministry of Health did declare a public health concern because there were cases that were identified in some of the areas close to the DRC. So this is quite alarming, but it's also just important to share some of these perspectives on global stages, on a global picture like this one that we have at the moment. So yeah, thank you so much for the conversations, and happy to hear more.
So, Dr. Mabel, I have a question for you. As a practicing physician in a local context where you spend a lot of time with youth, getting information about health issues out, responding to the question that Wendy asked, about how do you communicate at the local level? What are some of your experiences? I hate to put you on the spot,
Oh, yeah.
but just
So,
give the top three. Yes.
yeah, so just the background, I do work a lot in the grassroots, and most of my work is around connecting communities to and linking them to health services. And currently I work with young people in sport. At the moment, we're really looking around menstrual health, as this month is menstrual health month, which falls on the 28th of May, 2026. So it's really interesting to hear how the young people communicate, because first and foremost, they're very honest about what they want to learn. Sometimes we go there with a whole package of what we want to give them. For example, there is a training kit on menstrual health and hygiene that the Ministry of Education has developed for Zambia. But when you go in and start having conversations, they will tell you exactly what they want to hear. They will talk about things that are very interesting. For example, there was one young person who clearly asked about menopause when the conversation was just about menstrual health. So you could see that they already have so much information, but they just don't know how to package that. So people like me actually then help them address those issues and also bring such conversations so that at policy level, we are actually responding to individual needs, to contextualize needs of the young people, other than having a whole prescribed package that's already existing. I think it's important to always go back, listen, and then tailor whatever you have towards what they really want to hear, because sometimes you may just miss their needs and what they really want to hear in terms of the miscommunications on the ground. So those are some of the examples that I can share in real time, because I'm currently working with these young people at the moment.
Yeah.
Okay, thank you. Go ahead, Srikanth.
Yeah, I'll
yes.
just take a couple of seconds to address or to answer Wendy's question. So it's true that we can communicate local messaging to the highest policymaking processes or through the policymaking process, different levels. But then, as opposed to this, it's hard to communicate global policy narratives to the local communities. So I can give you an example here. So we are exactly, again, at the right time to discuss this point, because there is an outbreak there, Ebola outbreak in DRC and Uganda right now, as we speak. The new cases are being identified. But none of us on ground would know the IHRs, for example. This is a global governing framework, but I'm pretty sure about it based on my research experience and my interactions. Except the highest policymakers in those two countries, the communities would not know about IHR for sure. And then it's true that the Director General of WHO 2 days ago declared PHEIC inconsistent with IHR 12, Article 12, meaning that Article 12 requests the DG to convene the emergency committee and to take a decision whether to call it as a PHEIC or not. But then DG this time, unlike before, previous cases, so he did not convene an emergency committee meeting, and then he declared PHEIC. So kind of not adhering to the IHR, which is fair in interest of public health. But here is the point. So here is a miscommunication. Here is a disinformation now, because since WHO declared PHEIC, so this is highly misinterpreted by the member states in different countries, especially the DRC and Uganda. They would impose travel bans, etc., and so on, right? So, but PHIC does not necessarily mean imposing travel bans. So this is the communication aspect. So this is the thing that we need to sensitize both the policymakers of those two countries and elsewhere, whoever is trying to impose travel bans. And then how do we communicate that message further levels of the administration, like Mabel's said. So it has to, the information should get translated into the sub-nation level, at the local level, local administrations and municipal administrations, because they need to know about this global framework that is meant for global health security. I know there may be cost factors involved in it to get that message to get people know about IHR across the levels. So, but regardless of those cost factors, and it has to be disseminated across the system, right? So it shouldn't be sticking with the national focal points of DRC or Uganda, and that information needs to go across the system. Then only they would be more confident. I mean, the local communities and local civil societies would be confident about, well, there is a PHAC, there is an outbreak, but nothing to really worry about. So we could significantly reduce the panicking attempts and the stress and the anxiety that we create, that was created by this outbreak, just by informing about this IHR across the system.
Yeah.
So this is how I see it should be. It's hard to convey those, communicate those global policies across the system, especially the local context. Right. But on the other hand, it's easy to communicate the local best practices with policy purposes.
Policy, right. I think this is ripe for further discussion, and I'd like to say, so what do we do? I always come away with, so what do we do? When Wendy raised a very good question that is stimulated and interconnects with a lot of what we're all working on. I would like to invite all of you back on July 9th, Thursday, July 9th. Please, hopefully it fits on your calendar. When Srikanth is going to present on the IHR, for us to have a continuing conversation, and then post that, think of how we can pull together a proposal for a policy brief on this, because this is critical. We have these regulations, we have this information, but the same as with the SDGs. But there's a divide between what the community knows and understands, and what we're talking about up here. And it's from this push up from the community where action needs to happen. Local, municipal, and this just fits right into my shtick, which is why I started Urban Health 360. So let's continue this. We're at the 2-minute mark before 10:30. I know you've got schedules and all of that, and we don't want to mess up our schedules. Let's make a commitment to continue this dialogue and to find a way to turn this into some kind of policy brief that leads to policy action at some level. Okay? So thank you at 10:29. Thank you, Srikanth, for stimulating us for this important discussion. Thank you all, each of you here, staying to the end and giving your insights, which is critically important, which is why we have the seminar series. So with that, I will bring this particular inaugural session to a close, and we look forward to more action coming. And each of you will be presenting over the course of the 2 months, so we have more time to talk and engage. Okay? July 9th, put that on your calendar, in your diaries, so that we can continue. Thank you so much.
Thank you all.